Good morning, everybody, and good morning to those watching remotely. Welcome to our first grand rounds of the 2018 academic year. Before we start, just a couple of kudos. And the first is from Brianne Dennis, who's an ARNP at Children's. And this is directed to Anthony Yee and Prash Bremjit. And Brianne Dennis said, "Thank you from the entire surgical hospitalist APP team. You both have been exceptional and go above and beyond the call of duty for our team. I know I speak for the whole team in saying that we all greatly appreciate you. It's been a pleasure. Thank you, Anthony and Prash." And the second one is for Matt Barron. And this is from Dr. Thomas Hay, who's the Associate Medical Director at UWMC. And Dr. Hay says, "Thank you, Dr. Matthew Barron, for your excellent care and time you spent with my patient." So thank you, Matt. Just a reminder for people who are watching remotely, feel free to text me if you have any questions during or after grand rounds. And this morning, we're going to talk about current controversies in anatomic shoulder arthroplasty. And Dr. Zahab Ahsan, one of our chief residents, is partnering with Jason Shu, who is an assistant professor with specialty training in shoulder and elbow surgery. Thank you, Zahab.
All right, good morning. Thank you for the kind introduction, Dr. Chansky. I'd also like to thank Dr. Shu for his mentorship on this presentation. And with a future career in sports medicine and a keen interest in shoulder surgery, preparing this talk has been very meaningful and enlightening. And in conjunction with Dr. Shu, I hope to share just a little bit of the knowledge that we've gained during this preparation for this talk, as well as focusing on some of the controversies that are on the horizon of anatomic shoulder arthroplasty. One of our founding fathers and former Surgeon General, Benjamin Rush, stated that controversy is only dreaded by the advocates of error. This quote serves as a preface to our discussion today, as we seek to address how advancement in technology and understanding in shoulder arthroplasty may introduce controversy. This controversy is viewed in a positive light. To begin our discussion, I'd like to ask for an audience poll. We will have a series of questions to highlight areas of controversy and to stimulate some thinking. Please join the poll on your cell phone by texting my name to 22333 or by using the link that's listed. Our case is a 59-year-old former basketball player who wants to remain active. He's presenting to our clinic with debilitating shoulder pain and stiffness along with these x-rays. How would you manage his glenohumeral arthritis? Would it be A, total shoulder arthroplasty, B, hemiarthroplasty or Ream and Run, C, reverse total shoulder arthroplasty, or D, non-operative management? All right, thank you. All right, pretty straightforward. Let's go one level deeper. In our 59-year-old male patient, if we proceed with total shoulder arthroplasty, what type of implant would you like to use to manage the humerus? Would it be A, standard length stem, B, short stem, C, stemless, or D, platform stem? All right, so let's say that this patient desired a total shoulder arthroplasty. What is the best modality to address the glenoid pathology as noted on the axillary x-ray? And those options include A, standard glenoid implanted in retroversion, B, standard glenoid with eccentric reaming to neutral glenoid version, C, standard glenoid with posterior bone grafting, D, augmented step glenoid, E, augmented wedge glenoid. All right, thank you for participating in the poll. These questions highlight some of the controversial topics in anatomic shoulder arthroplasty that we will review today. In order to better understand these topics and the evolution of modern shoulder arthroplasty, I will review a brief historical perspective, highlight an overview of surgical principles, followed by a closer look at the relevant normal anatomy and pathologic anatomy, and in particular how these relate to surgical principles. Following this, Dr. Shu will review the current state of shoulder arthroplasty implants and common controversies in anatomic shoulder arthroplasty. Modern shoulder arthroplasty can be attributed to the early efforts and intellectual creativity of some major pioneers in our field. This dates back to 1893 when French surgeon Dr. Jules Pien used a prosthesis in the shoulder to replace an infected tubercular joint. This was in a 37-year-old patient who was near death from septic arthritis. He utilized a platinum humeral shaft with platinum loops attached to a rubber ball glenoid. This was the first known attempt at joint replacement of the shoulder. Notably, this was preceding the first hip replacement by approximately 26 years and established the feasibility of joint replacement and laid the foundation for modern arthroplasty. The second phase of advancement occurred in the 1930s and 40s when Dr. Burke had introduced acrylic prostheses. These were used by many, and due to poor wear characteristics, they gradually began to fall out of favor. Dr. Kruger introduced the first modern shoulder arthroplasty for AVN in 1950, utilizing cementless Vitalium, which is a cobalt chrome alloy. This technique involved preserving the rotator cuff attachments. This was very important as it essentially became a critical aspect of shoulder replacement surgery, as we'll discuss further. The modern era of shoulder arthroplasty began with Dr. Charles Neer in the mid-1940s. As an orthopedic resident at NYU Columbia under Dr. William Dara, he became disenchanted with the outcomes of patients undergoing proximal humeral resection after proximal humerus fractures. In order to find a better solution, Dr. Neer first published his series of 12 cases in JBJS with shoulder arthroplasty for patients with proximal humerus fractures in 1953. This became known as the Neer 1 prosthesis. Dr. Neer reported that patients never had a problem with stem loosening as long as the device had been set firmly in the medullary canal at the time of insertion. He also noted that patients could engage in all types of activity, including farming and carpentry, without breaking, loosening, or painful glenoid erosion. Furthermore, Dr. Neer continued to use the Neer 1 component without any glenoid prostheses when the articular surface of the glenoid was normal. Dr. Neer redesigned the humeral component in 1973 to conform to polyethylene glenoid prosthesis. This design had the same radius curvature of Neer 1, but had rounded edges to prevent encroachment on the glenoid component, and this implant remained monoblock and non-modular. Second-generation implants introduced modular humeral heads and stems in the 1990s. This variability allowed for a better fit for the prosthetic head in the glenohumeral joint and into the humeral shaft. Modular heads also decreased technical demands on surgeons during revision shoulder arthroplasty, especially in the setting of a well-fixed, non-infected stem in which the head could be swapped out. These second-generation implants were usually uncemented, meaning that the humeral metaphysis dictated the alignment. Unfortunately, the modular components did not reproduce humeral head anatomy perfectly and were often overstuffed. As shoulder arthroplasty has become a routine procedure, greater than 60 years of clinical experience has been augmented by multiple studies that have detailed the geometry of the proximal humerus. Particularly with respect to the proximal humerus, this understanding has led to improved technology and design of implants. A third generation of implants was designed in the 2000s to allow for recreation of the anatomic humeral neck and head. These implants featured offset humeral heads and modular stems that allowed for adjustment of varus valgus as well as version. Most recently, a fourth generation of humeral components has been developed featuring short stem and stemless designs. These are not resurfacing implants, but rather are humeral head replacements that anchor exclusively in the humeral metaphysis. This offers theoretical advantages of preserved bone stock, less stress shielding, ease of stem removal at revision, and humeral head placement independent from the humeral shaft axis. To understand why this evolution of shoulder prostheses has occurred, it's helpful to review the surgical principles behind total shoulder arthroplasty. The goals of arthroplasty are to restore comfort, motion, and function that has been lost from arthritic deformation of a joint by replacing the humeral and glenoid articular surfaces. Factors that are involved in this successfully are restoration or creation of normal biomechanics, maintenance of anatomy, as well as surgical technique that balances soft tissues and produces solid fixation of durable implants. Ultimately, rehabilitation allows the patient to return to function. Looking at the surgical procedure briefly, for those that are not familiar, this figure depicts the main steps of shoulder arthroplasty. We begin with the delta pectoral approach, followed by subscapularis takedown to expose the glenohumeral joint. Once the joint is exposed, the humeral osteotomy is performed at the base of the articular surface while preserving the rotator cuff attachments. The next step is humeral side preparation with broaching and sizing. This is followed by glenoid preparation and ultimate trialing of implants and capsular closure with an emphasis on soft tissue balancing. Our clinical correlation today is a 65-year-old active female. She works as an airline stewardess with routine heavy lifting at work. She has left shoulder pain that limits her activities, and she wants to continue working and being active. We will discuss the treatment of this patient, and along this, we will highlight some of the principles of anatomic shoulder arthroplasty. The importance of anatomic reconstruction on the humeral side is depicted in this figure taken from a study by Dr. Harriman and Madsen. The top figure, figure A, depicts anatomically normal anatomy. The native shoulder is in 45 and 0 degrees of abduction in each figure here. 45 degrees, 0 degrees. An osteotomy of the humeral head is planned at the dotted line with goals to preserve the rotator cuff attachments. The middle diagram, figure B, demonstrates appropriately sized anatomic arthroplasty. This recreates normal anatomy and allows for normal capsular laxity and good range of motion. The bottom figure depicts the effective placement of an oversized humeral head and the glenoid component in total shoulder arthroplasty. The capsule and cuff are over-tightened, resulting in dramatic loss in range of motion. These figures illustrate the importance of correct sizing and soft tissue balancing with the insertion of implants. Moving on to the anatomy of the proximal humerus, it's known for its distinct variability, not only between individuals, but often between left and right sides in the same individual. This creates an innate challenge for arthroplasty surgeons. The humeral head is retroverted an average of 30 degrees from the transepicondylar axis of the distal humerus. Overall, this may range from 0 to 55 degrees. The neck and head of the humerus have an angle of inclination of approximately 130 to 150 degrees in relation to the shaft. One of the important variables of the proximal humerus to consider is head height. This represents the height of the articular surface. When we make the humeral osteotomy in our case, we are measuring the thickness of our cut, which is shown by the red line. This is planned to recreate the head height at the time of arthroplasty. On this figure, the black dot represents the center of rotation of the humeral head, which is bounded by the radius of curvature. The goal is to recreate appropriate head height and radius of curvature at the time by implant size selection. The distance between D and E in this figure depicts humeral head tuberosity distance. The superior margin of the humeral head articular surface normally is superior to the top of the greater tuberosity by about 8 to 10 millimeters. Restoring the center of rotation of the humeral head in relation to the center of the glenoid helps to prolong glenoid fixation and decrease polyethylene wear. If the head is placed too high, then stiffness can occur due to eccentric center of rotation and imbalancing of the rotator cuff. This may additionally cause rocking horse loosening of the glenoid. If the head is too low, below the tuberosity, but centered on the glenoid, then impingement of the tuberosity can occur on the acromion, resulting in decreased range of motion. Lateral offset. The distance from the lateral base of the coracoid process to the lateral margin of the greater tuberosity is the lateral humeral offset, represented by F to G. Maintaining this distance is important because a significant decrease reduces the muscle tension of the deltoid and the supraspinatus muscles. This weakens abduction and impairs function. A significant increase in offset causes excessive tension on these soft tissues, known as overstuffing of the joint, which results in a loss of motion and also is likely to accelerate polyethylene wear. This also puts the patient at increased risk for rotator cuff tear or subscapularis repair failure. Lateral offset is an important radiographic characteristic for ensuring optimal shoulder arthroplasty placement and obtaining rotator cuff tension. I'd like to introduce the perfect circle concept. Radiographically, this circular fit of the proximal humerus is a surrogate for sizing the humeral component. The left X-ray is an AP of the shoulder showing the humeral head relationships. The circle is positioned based on the lateral cortex below the flare of the greater tuberosity, the medial footprint of the rotator cuff at the greater tuberosity, as well as the medial calcar at the anatomic neck. The middle X-ray demonstrates a well-positioned humeral component in shoulder arthroplasty, replicating this perfect circle. The far right image shows an implant that is too high and invarus, effectively overstuffing the joint. Humeral head offset. The axis of the humerus is shown here in red. It is not in line with the humeral head articular surface, referred to as humeral head offset. This is best demonstrated in the figure on the right. The articular center of rotation, shown by this white dot here, is approximately 2 to 10 millimeters posterior and 4 to 14 millimeters medial to the humeral diaphyseal axis, which is again shown by the red. This is important for the surgeon to note while placing the stem and obtaining appropriate soft tissue balancing. The main goal is that if a concentric head is placed with the taper in the center, then you are not accounting for the posterior and medial offset. Eccentric heads. Due to this concept of posterior and medial offset in in the center of rotation of the humeral head, third-generation arthroplasty symptoms, as we discussed, began to account for this by introducing eccentric humeral heads. As depicted in the top figure, the eccentric heads shift the stem taper by 4 millimeters from the center of rotation. The image on the left in the bottom figure demonstrates the variability of coverage with offset humeral heads. The yellow dot is in the center of rotation of the humeral head, and the red dot is in the center of the stem. The middle figure displays posterior inferior offset. This is the most commonly used offset system that helps to cover the humeral osteotomy site. The right figure shows that the eccentricity is moved anteriorly. This is useful for shoulders with posterior shoulder instability. Moving on to glenoid anatomy. The glenoid cavity has a pear-like shape in the sagittal plane with wider appearance inferiorly as opposed to superiorly. The glenoid cavity faces slightly cephalad by 3 to 5 degrees and posterior by approximately 7 degrees. This measure is known as retroversion. This line is going through the body of the scapula to the center of the glenoid face, and it is important to appreciate that the glenoid face is retroverted approximately 7 degrees from this line. One of the challenging components of shoulder arthroplasty is management of the glenoid. The Walch classification was initially published in 1999 to address glenoid morphology, and it serves as an excellent segue into our discussion of management of posterior glenoid deficiency. The classification narrowed the glenoid morphology into 3 types based on CT scan findings. Type A, the head is centered and glenoid erosion is central. The severity of the erosion is either minor, A1, or major, A2. Type B, the humeral head is subluxated posteriorly with asymmetric load distribution and involvement of the posterior margin of the glenoid. In type B1, there is joint space narrowing posteriorly with subchondral sclerosis and osteophytosis, as in arthritis. In type B, the glenoid is eroded with the development of a secondary concavity. Type C glenoid is defined as retroversion greater than 25 degrees. This is a consequence of glenoid dysplasia or hypoplasia as opposed to erosion. In an effort to improve intra-observer reliability, recent modifications have occurred. And in 2016, an expansion to this classification was released. The B3 glenoid introduced as a monoconcave and posteriorly worn glenoid with at least 15 degrees of retroversion or at least 70 degrees of posterior humeral head subluxation. And then the type D glenoid was also introduced, defined as any level of glenoid anteversion or with anterior humeral head subluxation, so essentially the opposite of what's going on in B. The Walch classification was initially described with the use of a CT scan, but can also be applied with a good axillary lateral X-ray. This is a topic of controversy in and of itself. This is the axillary lateral view obtained with the arm in a position of functional elevation that demonstrates joint space obliteration and glenohumeral arthritis. This view is also referred to as the truth view, as it provides keen insight on characteristics of the glenoid that may be assessed for preoperative planning in the setting of anatomic shoulder arthroplasty. 2 topics that we'll discuss include glenoid retroversion and posterior subluxation of the humeral head, which may result in biconcavity of the glenoid as described by Walch. Glenoid retroversion can be quantified on the axillary lateral view as initially described by Dr. Friedman. The axis of the blade of the scapula is established, and a perpendicular is first drawn at the anterior extent of the glenoid, shown in black. The red line is then drawn tangent to the anterior and posterior edges of the glenoid fossa, calculating the angle of glenoid retroversion. The figure on the left is a technical schematic demonstrating this calculation. As previously noted, glenoid retroversion averages about 5 to 7 degrees, but ranges from 2 degrees of anteversion to 11 degrees of retroversion. Any angle greater than 10 degrees of retroversion is considered pathologic. Humeral head subluxation. This figure depicts a method to quantify posterior subluxation of the humeral head. It allows us to compare the point of contact of the humeral head on the glenoid relative to the midpoint of the glenoid face. There is a controversy whether posterior humeral subluxation should be measured using the scapular body line or a line perpendicular to the glenoid face. We will discuss that on the next slide as well. This technique begins with a line tangent to the anterior and posterior edges of the glenoid, followed by a perpendicular line bisecting the glenoid that's placed. We then measure the percentage of the humeral head, which is posterior to this line, to establish an index of subluxation. As I previously mentioned, the method of humeral head subluxation measurement is a controversy amongst shoulder surgeons. This shows a comparison to an alternative technique for measurement of humeral head subluxation. Method 1 is our previously discussed technique, which is based on the line perpendicular to the glenoid face. Using this method, there can be a minimal humeral head posterior subluxation, even in the presence of severe glenoid retroversion. Method 2 is a method of subluxation based off a line through the body of the scapula, which is centered over the glenoid. The percentage of the humeral head that is posterior to this line is then calculated using a similar technique. Using this method, posterior subluxation of the humeral head will be present with any degree of glenoid retroversion. Therefore, it stresses the importance of obtaining neutral glenoid version during surgery. Back to our 65-year-old airline stewardess who is ready for standard total shoulder arthroplasty. This AP view of the right shoulder demonstrates classic signs of glenohumeral arthritis with joint space obliteration, inferior osteophyte formation, and the presence of subchondral cysts. There is no evidence of rotator cuff arthropathy, which may be reflected by superior subluxation of the humeral head or acetabularization of the acromion. Maloney's line here is depicted in red, showing that the humeral head position is maintained and indicating rotator cuff integrity. Looking at the axillary view on the right, we appreciate a Walch A2 glenoid, a well-centered humeral head with minimal posterior subluxation, and minimal glenoid retroversion. This is our postoperative X-ray after undergoing left total shoulder arthroplasty with a short stem total shoulder arthroplasty. This can be evaluated based on some of the principles that we've discussed today. Taking into account the perfect circle concept, the humeral implant appears well-sized with recreation of the head height and radius of curvature. Looking at Maloney's line, the humeral head is appropriately positioned in the axial plane. Head-Tuberosity Distance is maintained with appropriate capsular tension. And lateral offset is also maintained, indicating appropriate tensioning of the rotator cuff. On the lateral X-ray, the humeral component appears well-centered on the glenoid. Ultimately, we can see that the native anatomy has been appropriately replicated, resulting in an overall well-positioned total shoulder arthroplasty that restores soft tissue balance. At this point, I'd like to transition to Dr. Xu, who will be expanding on our discussion of controversies of total shoulder arthroplasty. Thank you.
All right, thanks for the great intro. That went over a lot of the important concepts that I'm going to go over in my presentation that actually talks about the controversies and the new implants that we're using these days. So this is my disclosure slide. Some are which of are relevant to this discussion. So we showed this case at the very beginning. This is a 59-year-old former basketball player who's got a biconcave glenoid showing severe posterior subluxation. I think the live poll results show that the majority of people would do a Ream and Run and use a standard length stem. If we were to do a glenoid component, I think most people picked eccentric reaming and a standard glenoid component. So this is a difficult problem with a lot of potential options, and my goal today is to give an unbiased review of the pros and cons of the recent advances in the new implants that we're using in anatomic arthroplasty and discuss the controversies surrounding them. So there have been a number of new developments in anatomic arthroplasty over the past 5 or 10 years. We can start with our 3rd generation standard length humeral component and pegged poly glenoid as a baseline. On the humeral side, there are now short stems, there's stemless components, there's platform stems which allow for conversion to a reverse arthroplasty from an anatomic arthroplasty. And then on the glenoid side, there are new step augments, there's wedge augments for addressing glenoid biconcavity, and there's also a number of hybrid glenoids that exist. It's important to understand that each of these has potential advantages, but there's also limitations to using each of these, and that's what I'm going to review today. So there's 3 points that I want to address. First are questions. First is, should we go short or stemless on the humeral side? Second is, what are the pros and cons of using a platform stem? And third, are augmented glenoid components the solution for B2 or B3 glenoids? So let's look at the first question, which is whether we should be using short stems or stemless components. It's important to look at humeral component design and look at characteristics that we're looking for in a stem and a humeral head. So first, it has to be able to anatomically position the humeral articular surface, and we want to make sure that we also get good initial fixation so that we can start early motion during rehab. We also want durable fixation and without any stem loosening over long-term follow-up. And lastly, it has to be easily revisable because the number of shoulder arthroplasties we're doing is going up, especially in young patients, and the burden of revision surgery is expected to be pretty large in the next couple of decades. So we just demonstrated anatomic positioning in total shoulder arthroplasty, and this is a regular length stem on the left. We can see all the variables that Zahab went over, including version, tuberosity head height, ensuring center of rotation of the humeral head matching that of the glenoid. We achieve that with a regular length stem. We can also achieve that with short and stemless components. As you can see here, using that perfect circle concept, the center of rotation does match up with the glenoid as well. The question is, what are the pros and cons of using these kinds of implants? So to go back to looking at our goals with a standard length stem, it's important to see how do we achieve good initial fixation with a standard length humeral stem. There's two ways that we can do this. First is we can get metaphyseal fixation, and the second is that we can get diaphyseal fixation. Obviously, those that are dependent on diaphyseal fixation have to have standard length stems, but this can be an issue, as Zahab went over. If you use a diaphyseal fitting stem, you may have premature diaphyseal contact, and that leads to high stem and poor anatomic reconstruction. You can see that the tip is incarcerated into the diaphysis, and it's in various leading to an overstuffed joint. Short stems can achieve metaphyseal fixation without any diaphyseal contact, and this can be useful in some cases in which the humeral canal is narrow. So if you look at this patient who has a very narrow diaphysis, if you were to place a regular length metaphyseal stem, even though it's a metaphyseal stem, your diaphysis could potentially get incarcerated before you get proper seating of that stem. So in this scenario, short stem could potentially get better metaphyseal fixation than a regular length stem. So in cases of altered proximal humeral anatomy, like proximal humeral malunion, short stems or stemless components can be potentially useful. So stemless components take things a step further. They engage the metaphyseal bone without any stem, and so the surgeon can dictate the location of the humeral articular surface without referencing the canal at all. As Zahab reviewed, the anatomic reconstruction using a stem typically requires eccentric head to properly account for the medial and posterior offset. So just to review one more time here, the stem, center of the stem here is in red, and the center of rotation of the humeral articular surface on the osteotomy is here in yellow. So originally the eccentric heads were made with the eccentricity facing posterior and medial to account for the offset between the stem and their center of rotation. So you can see with a stemless component, you don't have to worry about that, and you can just make an osteotomy and dictate the placement of the humeral head independent of the stem. There's also a theoretical advantage that at revision, these components might be easier to take out without any chance of tuberosity fracture. There's definitely limitations to these stemless components, though. Version and inclination are not guided by a stem referencing system, and so you don't have any guide from the diaphysis at all. So the surgeon has to essentially make a perfect osteotomy without stem referencing. And this was achieved in this patient on the top left here, but if you look at this x-ray here, this is a patient with osteopenia. The osteotomy was not placed in a great position, and there's no ability because you don't have a stem to correct that, and so this patient had early failure. Stemless humeral components have been used in Europe since the early 2000s, and we've only recently had approval here in the United States with one implant system, but there's a number of them that are in the IDE process right now. This was a recent prospective multi-center study that included 149 patients. They used a stemless arthroplasty and reported good results with no patients having any osteolysis or loosening and a low complication rate overall. It is important to note that these are experienced surgeons that are doing these surgeries, and they have strict indications for these stemless implants. So we'll have to see what the longer-term results are and what the results are in the hands of less experienced surgeons. So to summarize the pros and cons of a stemless design, your head position is not dictated by the canal, and you potentially have reduced morbidity during revision surgery because you don't have loss of bone stock with stem extraction. But there are definitely limitations with stemless designs where you don't have any diaphyseal reference, and your osteotomy dictates your prosthetic positioning. And if you don't make a perfect humeral osteotomy, then you could end up with a failure, early failure. So let's move on to our next controversy, which is platform stems. We talked about features that are desirable in a humeral component design. One of them is that it should be easily revisable. So platform stems allow for revision from anatomic to reverse prostheses without any stem removal. And this is desirable because it prevents the need to remove a well-fixed stem and the morbidity associated with implant extraction. So here's an example of a difficult revision of a hemiarthroplasty. This is a trabecular metal stem. The surgeon implanted this with cement in the humeral canal. And you can also see that the bone quality of the tuberosity is pretty poor. So all these things made extraction really difficult, and an osteotomy was used to remove the stem. And because the tuberosity bone was poor in quality, the tuberosity fractured and couldn't salvage it at all. So you can see that a reverse was placed, but the tuberosity is not present, and the rotator cuff is no longer intact here. This puts the patient at risk for a poor functional outcome, also dislocation due to poor soft tissue tensioning, and there's increased risk for stem loosening as well due to the forces from a reverse arthroplasty. So platform stems, they facilitate conversion from an anatomic to a reverse without stem removal. So you can see here that there's you can convert here, keep this part of the stem in the medullary canal, and convert this to a reverse without having to do an osteotomy. So a recent study on platform stems was done looking at 73 patients that needed extraction of the humeral stem, and then 29 patients that used a platform stem where it was converted to a reverse without stem removal. And they found that platform stem saved over an hour of operative time because they didn't have to work on stem removal, a lot less blood loss, less intraoperative complications, and they had better post-op motion, likely a result of retained proximal bone and soft tissue. These platform stems do have their drawbacks, though. It's important to look at the requirements to keeping a stem. One is that there can't be any infection in there because if there's a biofilm, that might cause issues down the line. Also, the original implant has to be put in a good position. If it's too high or it's in the wrong version, it may not be convertible. And then finally, the design has to be good where there's adequate modularity to tension the soft tissue as well. So one of the big questions with platform stems is the status of infection at the time of surgery. And we know that P. acnes is the most common bug found in shoulder replacements at the time of revision. So this was a landmark study added here a few years ago that demonstrated that over half of patients had positive cultures at the time of revision surgery. But the big problem here is that in the shoulder, we don't know whether a shoulder is really infected or not at the time of surgery, and we don't know the results of the culture until days to weeks after the surgery is complete. So at the time of revision, the surgeon doesn't know whether bacteria is present or not. So if you look at this stem here, the big question is, when you're doing this surgery for pain and stiffness and you're trying to convert this from an anatomic to reverse, should you take the stem out? And there's really no good way to know until after the surgery is done. Another requirement of using a platform stem is that you have to place the stem in a good position at the index surgery, otherwise it's very difficult to revise. So if you look at these two x-rays of platform stems, you can see that they were implanted too proud. So the humeral head is just too high relative to the tuberosity. And if you're trying to convert this to a reverse, you might have a lot of trouble with a difficult exposure and very difficult surgery. So platform stems, there's some pros which include saving the morbidity of stem removal. You have shorter operative time, less blood loss, lower complication rate overall. But some limitations, you don't know the status of infection at the time of surgery. And then you could have a very difficult revision if the stem was placed poorly at the index surgery. So you can consider using these stems if you are doing a surgery where you think the indications for anatomic are stretched and you're worried about needing conversion to a reverse. So you might consider that option in those scenarios. So the next controversy here is the management of the B2, B3 glenoid, and it's the most likely the most complex and controversial of the topics today. This axillary view, it shows a patient with concentric glenohumeral arthritis that Zahab had gone over. I think most people would be fine using a standard glenoid component, and that patient would do fine with that. But what about these patients with more severe glenoid deformity? On the left, you can see a patient has posterior decentering, whether or not you measure that from the scapular body or perpendicular to the glenoid face. And then on the right is a patient that has severe retroversion. Again, Zahab had mentioned a controversy on how to measure posterior subluxation of the humeral head, and on this x-ray, it's severely posteriorly subluxed if you look relative to the scapular line here. But if you draw a line just perpendicular to the glenoid face, it's not posteriorly decentered if you use that method. So the question is, what implant would you use to address this glenoid deformity? So there are a lot of options here. You could implant the glenoid in retroversion and address decentering on the humeral side, which I'll go over. You could correct version a number of different ways. You could do eccentric glenoid reaming, which I think on the live poll was the most common answer. You could use an augmented glenoid, which I'll go over. You could use posterior bone grafting. Because this is such a difficult problem to address, some people might not use a component at all and do a Ream and Run. And then there's reverse arthroplasty. So there's a lot of options here, not necessarily a clear winner, but we should go over the pros and cons of each of these options. So let's look at accepting retroversion and addressing decentering on the humeral side. The overarching goal is to get a concentric joint with good soft tissue balance, and this is, despite being a non-anatomic approach, it can be very useful to address this problem. So the concept here is that you ream the glenoid to a single concavity. So this line here is in line with the scapular body, and you can see that our glenoid retroversion is shown here in red. Our goal here is not to ream to neutral version, but really to accept the retroversion and just get to a single concavity. On these x-rays here, this is actually what was done with the patient. We did a total shoulder arthroplasty where we reamed to just a single concavity, accepted retroversion, and used an anteriorly eccentric head to keep the humeral head concentric within the glenoid. And so the patient did very well with this. It's actually commonly accepted in the orthopedic community that glenoid version should be corrected. It was based off this study that looked at 66 shoulders where they measured the amount of retroversion that the implant was inserted, and they found that implantation of glenoid components more than 15 degrees was associated with central peg osteolysis, but the clinical outcomes weren't any worse with implants in retroversion. We performed a similar study looking at 71 shoulders. 21 were implanted with the glenoid in more than 15 degrees of retroversion and 50 without. And we found no difference in glenoid central peg osteolysis or loosening, and no difference in patient-reported outcomes or reoperation. It is important to note that there are some differences in surgical technique between these two studies, and in particular, as we had mentioned before, we commonly use the anteriorly eccentric head to ensure that the humeral head is concentric within the glenoid. And so I'll go over that concept here. So we have this patient with a posteriorly decentered humeral head. You can see here, this is a line with the scapular body, and the humeral head is posteriorly subluxed. Again, going over this concept, the center of the humeral stem here is offset to the center of rotation. The center of rotation of the humeral head is actually posterior and medial to the humeral stem. So the original designs of eccentric heads were to compensate for this by putting the eccentricity posteriorly and inferiorly. There can be issues with that, though, because if you have severe posterior subluxation and you put the center of rotation posteriorly to cover the humeral head anatomically, you may end up with something like this, where you have posterior eccentricity and your center of rotation is matching the anatomic proximal humerus. But if you look at the line going through the glenoid, this is obviously posteriorly subluxed dislocated. So we actually use the eccentricity of the head going the other way to compensate for posterior subluxation. And so instead of having the center of rotation of the head posterior and inferior, we move it anterior to help to compensate, and that's what we did with that this patient here. You can see the glenoid was placed in retroversion. We moved the eccentricity of the humeral head anteriorly relative to the stem, and we're able to get a concentric head within the glenoid. So I just wanted to show some videos to demonstrate this concept. So this on the left is what the original intent of an eccentric head was to match the humeral osteotomy, but during trialing, during surgery, what we see here is that what we do when we push the humerus backwards and we raise the arm and forward flexion, the humeral head doesn't want to stay concentric within the glenoid, and it wants to sit back a lot. So that patient's at higher risk for posterior instability and rocking horse loosening of the glenoid. So what we did, this is a trial. We move the eccentricity anteriorly to move the center of rotation forward. And you'll see on this video here that once we do that, the bounce back is much better. And when we forward flex the arm, there's no posterior instability. So we studied this in a large number of our patients, and using this technique of accepting glenoid retroversion anteriorly, using an anteriorly eccentric head for any intra-op posterior decentering, and adding a rotator interval plication, we were able to get good results in the majority of patients. So on this graph here, preoperative decentering here is shown on this axis here, where higher numbers indicate more decentering. And you can see we have some pretty high levels of decentering preoperatively. Postoperatively, using anteriorly eccentric head and even accepting retroversion, we see that we're able to get the heads concentric within the glenoid. And using this technique, we also reviewed a few hundred of our arthroplasties, and you can see down here that even using this method to address B2 and C glenoids, our results at 2 years are comparable to A2 and B1 glenoids. There are some potential limitations to this technique. So if you have very severe retroversion and you implant the glenoid, you could get perforation of the glenoid vault, and so your peg may not be contained. That may be considered a limitation, but it depends on what implant you're using and whether that affects your clinical outcome. The other potential limitation, theoretically, is that your subscapularis repair is tension because you're anteriorly moving the articular surface anteriorly over the lesser tuberosity, and so theoretically your subscapularis has to go over the implant. So let's go over some of the other treatment options that correct glenoid version. So we have eccentric glenoid reaming, we have augmented glenoids, and posterior bone grafting. So eccentric glenoid reaming uses a standard glenoid component, and the key here is that you want to correct glenoid version. So you can see here that you have a biconcavity, but what you're trying to do is get neutral glenoid version by taking away the anterior rim of glenoid bone. You can see that you do have to remove a fair amount of bone here in order to get that glenoid to seat. So there are definitely some limitations. If you accept retroversion, this is 0 degrees of version correction. You can see that your reaming depth is lower and the amount of resected bone that you're taking out is minimal. Whereas if you correct version, the more version you have to correct, you're taking a lot more glenoid bone out, and the resection line is pretty substantial. So you do have to put a smaller glenoid component, because as you can see, as you go more medial, the surface area of the glenoid decreases. So there are definitely some limitations with that technique. Posterior bone grafting tries to address that posterior biconcavity by adding bone rather than removing bone. This is a technically very difficult procedure. As you can imagine, it's hard to get to the posterior glenoid. The concept here is that you can take humeral head or iliac crest and match that to your defect and then use 2 screws to get fixation. As you can imagine, getting this bone graft into the posterior shoulder and getting good fixation can be technically very difficult. And then there's newer implants out. There's augmented step glenoids or wedge glenoids where the concept is to actually fill in that area with plastic rather than, or polyethylene rather than bone. So you can see here that you have a biconcavity on the axillary view here. During this technique, what they do is they put a guide wire in. They resect a little bit of the posterior bone to match up with the step that's on the polyethylene component. You can pick a 2 millimeters or 4 millimeters on the posterior step depending on how much bone loss you have. And then you can see on this post-op x-ray that anteriorly you have the polyethylene sitting on the existing anterior bone, and then you have this step here, which is the step of polyethylene that brings the joint line in, out laterally and also obtains neutral version. So one of the perceived or theoretical advantages is if you do eccentric reaming, you take away the anterior bone, you have to medialize the joint line, and that's not as good for your cuff tension. Whereas if you put a posterior augment in and bring the joint line out again, the proponents of using this say that you get some better cuff tension. But there are definitely a glenoid, and with a standard glenoid component, that lever arm is smaller between the central peg and the posterior lip of the glenoid versus an augmented glenoid where that lever arm is larger. So it'll be interesting to see what the longer term results of this new implant are, but with this longer lever arm, there might be a concern for glenoid loosening. Going through the other options here, we can consider just not using a glenoid component at all and doing our Ream and Run arthroplasty. So one of the big reasons to do this is because the weakest link to total shoulder replacement is the glenoid. We reviewed a number of failed glenoid components, which include poor technique with bone cement behind the glenoid component leading to loosening, severe glenoid wear causing polyethylene debris and a loose humeral stem, and then something that's not really reported in the literature much, of dislocation of the glenoid component, whether it's polyethylene or pegged components, hybrid components, or metal-backed implants. So the Ream and Run procedure just doesn't use a glenoid component at all, so you don't have to worry about glenoid loosening. So this is a 30-year-old that had pretty severe capsulorrhaphy or arthropathy, and you can see a pretty severe amount of retroversion and biconcavity. And we did a Ream and Run arthroplasty. You can see that we accepted retroversion. We got the glenoid to a single concavity, and this patient did very well with this. In terms of our results, we are getting similar results between total shoulder arthroplasty and Ream and Run at 2 years. You can see here that the Ream and Run's in red and the total shoulders here is in blue. These are different, patient populations. Typically, the Ream and Run patients have to be your more motivated patient that are willing to do rehab and kind of push through the pain after surgery. And bone loss. So if you look here at the lateral offset, originally it's measured here at about 2 millimeters between the center of rotation and the of the humeral head and the lateral part of the acromion. And over a 2-year period, there is some medialization that can occur with the Ream and Run since there's nothing protecting the glenoid bone. In this study, though, we didn't find that there was any association with any inferior clinical outcomes, so we'll just have to follow these more closely. Longer term, the functional outcomes are fairly good. If you, there's a recent report that looked at Ream and Run longer term, and you can see that at a minimum of 2 years and an average of 4.5 years, our simple shoulder test scores are about 10, and that was reported a few years ago. And then more recently, with a minimum 5-year follow-up, an average of 10-year follow-up, the results are pretty stable from a functional standpoint. So even though there's a risk of medialization, the clinical outcomes have been pretty good. And lastly, we'll go over reverse arthroplasty. This talk was about anatomic arthroplasty, but there are some people that are doing reverse arthroplasty for these B2 and B3 glenoids. If you look at this patient here with severe retroversion of the glenoid and not a lot of bone stock, this is a 75-year-old. You can correct posterior instability with a constrained prosthesis. One of the other advantages of doing a reverse is that because you have screws into the base plate, you can incorporate bone graft immediately and get good fixation with these screws. So this is a reasonable option for more elderly patients with limited bone stock and difficult exposures due to glenoid retroversion. But there is a question of durability given the constraint of the reverse prosthesis. So just to go over this last controversy, which is pretty complex, one option is implant the glenoid in retroversion and use an anteriorly eccentric head. You can use the pros are that you can use a standard implant. You can do intraoperative trialing and adjust intraoperatively. Potential downsides are peg perforation and subscapularis tension. Eccentric glenoid reaming also doesn't, you use a standard implant. It's not as technically complex. The potential downsides are that you medialize the joint line, you take away more glenoid vault bone, and you have to use a smaller glenoid component. And then posterior bone grafting and augmented glenoid, the goal is to restore the joint line and also get neutral version. But both of these are technically difficult, and posterior bone grafting relies on the graft incorporation, and augmented glenoids has that longer lever arm that may lead to osteolysis of the central peg. We'll have to see what the longer term results are with that. Ream and Run arthroplasty is a good option for patients that are well motivated. There's less restrictions. You don't have to worry about polyethylene wear that may lead to humeral component loosening. The potential limitations are the medial glenoid wear that can occur and the difficulty in rehab for some patients. And then reverse arthroplasty is an option for more elderly patients where you can use the implant constraint to fix posterior instability, but it does have questionable durability given the constraint of the implant. So lots of newer innovations and designs out for shoulder arthroplasty, including stemless components, platform stems, augmented glenoids, and we have limited experience and limited long-term data with these new devices. We'll continue to watch closely for these results to come out. But most importantly, you have to realize that each of these were designed to facilitate better patient outcomes, but each of these has limitations that need to be recognized to avoid errors that can lead to failures and poor outcomes. Thank you.
People stand for questions.
We have time for questions.
So we're supposed to stand behind this.
Oh, okay.
That was a great set of presentations. Thank you very much. I think that you covered the waterfront very, very nicely. The only comment about the new innovations is just to remind ourselves that each new implant has its own learning curve. I think you emphasized that a little bit. And I'm sorry. Do I have one? Oh, I'm sorry. You usually don't have to use a microphone.
They can't hear you.
I know, but the point is made that each new innovation has its own learning curves. And so, as Jason nicely pointed out, it sounds great to put in a platform stem so that you wouldn't have to completely revise it. But as he also pointed out, you've got to get that thing positioned just right and hope like everything it doesn't get infected. The second point about new innovations is that we won't find out what the complications are related to them until years down the line. So we want to be careful about jumping to a new ship before we know whether it's going to sail well. And the last thing is to just think a little bit about the costs of these new innovations. You can imagine that a platform stem costs a whole lot more than a single stem impaction grafted. And so we want to make sure that there is a benefit realized to the patient for this theoretical advance of technology. So if you look over all the cases that you showed, you can see that each one of these new advances is likely to cost more if it has lots of different parts to it, or has lots of different finishes, or has a new modified posterior backside or whatever. There's going to be a cost involved in the research and development and the marketing of that. So just those 3 points, just make sure that we understand the learning curve, make sure that we understand that there may be unforeseen complications of new technologies, and the third is to make sure that we understand the cost of the new technologies as we make the decisions about how to proceed. But thanks for a great set of presentations.
Thank you. Thank you.
Yeah, thank you both. That was fantastic, both Sahab and Jason. I have a question sent to me from Harborview by Jonah Aber-Davies, and his text reads, do you worry that the retroverted glenoid will see an increase in early failure in the 2 to 10 year post-op period versus perhaps 20-year survival for most standard total shoulder arthroplasties?
That's a good question. I mean, we haven't seen that here in implanting glenoids in retroversion. Again, it all depends on whether you get a good concentric head within the glenoid. I think if even you implant a glenoid in retroversion, but you have a good concentric head within the glenoid during motion, then you don't get the rocking horse loosening. And that's why I think that using the eccentric head to make sure that you don't get that posterior decentering is so important. We don't have 10, 15-year follow-up for any of these, so I can't necessarily answer that question, but we have seen good results with it so far.
Again, I want to thank the lectures. It was terrific. But I wanted to, as somebody who loves Physics 101 and vector forces, it was a great lecture. But I think it's still very dependent on the bone quality. And it looks to me in the literature that no one has really studied osteoporosis of the scapula or glenoid very well. And maybe that is going to be a real index that you need for future development and for the decisions. So I'd be interested in your thoughts of it. I actually thought that maybe we could actually biopsy bone and get an osteoporosis factor rather than maybe the scanning. Maybe a localized one would be better.
Yeah, that's a great point. There have been a couple studies looking at bone density, and but there's nothing that shows a correlation between glenoid loosening and poor glenoid bone quality. Theoretically, though, if you have a patient that has a lot of osteoporosis, you do have to worry about that bone quality and early glenoid loosening, and you know, that's just something that you have to take into account when you're doing the surgery. So I brought that up during the stemless. You know, there's newer stemless components. If you have someone with osteoporosis, you definitely don't want to be putting in a stemless component because you don't have enough fixation. So I think every patient's a little bit different, and that's something that we would take into account for each surgery.
Yeah, I think you're aware that UW Medicine is talking about developing a core 3D printing facility, both for teaching and clinical use. And there's a lot of questions about whether that's reimbursable at this point, but I'm just wondering, is there any role for something like that just in terms of preparing for these cases where there's complex glenoid anatomy? I know I've heard some other shoulder surgeons from other academic institutions talking about using that to prepare for cases.
Yeah. Well, I think there are some surgeons which are looking into patient-specific instrumentation. That was going to be my fourth bullet point, but I didn't have enough time. Those require a lot of planning with CT scanning. You have to send off, you know, the CT scan and have a custom-made implant. The cost, again, is higher, and there really isn't any evidence yet to show that the clinical outcomes are any better, but we'll have to wait and see.
Two quick comments about the osteoporosis. We have published a few theoretical papers based on finite element analysis that if the bone is osteoporotic, the implant needs to be changed, you know, whether it needs bigger for spine implants and so on. Another one is for modularity. Whenever there is two components, there will be some micromotion, and in the very long term, it might produce some more wear particles and so on.
Yeah, that's a good point. The modularity with some of these newer components is just another spot where you could have a failure. So I didn't talk about that, but that's a great point.
Yeah, that will be in 5, 10 years. You know, we'll know.
Mm-hmm.
So good, you guys. Thanks for the talk. I wanted to have Zahab's thoughts on the downside between the short stem and the long stem. I feel like I got a good flavor of the stemless, but not as good of a flavor of why not or why to do a short stem versus a long stem.
Sure. The short stem is kind of a progression from the long stem, whereas you're relying on more of a metaphyseal fit as opposed to diaphyseal fit. As Dr. Shu mentioned, a stemless component would not be ideal in osteoporotic bone, but a shorter stem may still have some ability to have good bone purchase. Additionally, that's, going forward, we talked about ability to explant at revision, and with a more metaphyseal fit as opposed to diaphyseal fit, you're more likely to be able to revise a short stem down the line with ease.
So then, when would you not use a short stem compared to a long stem?
That's where the controversy lies right now. I think that's something that we're trying to address. I think long-term data is most relevant and most present for our longer stems. And since the short stems have only been out for about 10 years or so, I'm looking forward to seeing how long-term data shows that.
That's a good question, Chris. We don't have any data showing one is better than the other. I think that most of all the longer-term studies on humeral stems show that the standard length stems have good results, so why switch? Shorter stems do have some advantages when you have altered proximal humeral anatomy. My personal view is that if you can get good metaphyseal fixation, whether it's short or standard length stem, just make sure you use an implant that's easily revisable. So, if you use a regular length stem, here we use a smooth stem that's easily revisable, but many of the stems that are out there now have ingrowth, and that makes it very difficult to explant. So a regular length stem that's smooth is easily revisable. Same thing with a short stem, you just don't have to worry about any of the fixation diaphyseal to remove when you revise it. So I think it's also very implant specific. We don't have any long-term data on short stems yet, so we'll have to see if those hold up as well as regular length stems.